Hello,
Hello,
my friend.
hello, my friend.
Good to see you, man.
Nice to see you too.
Yeah.
Looking great.
Yeah,
Seems
you too.
the time doesn't get over from you. So
Oh,
you
it
are still
does.
young.
Trust me, it does.
It does.
It
Okay,
surely does. So people are
perfect.
coming in, and it's a great pleasure, man, to be here with you. Such an honor. I can see you are set up. You are in your training center. Can you show that to us a little bit?
Yeah, for sure. I can just make some small tour around. Let me take my phone from the holder and I will try.
Okay, please do that.
This is our
Oh, that,
force dental, wings of dental force. This is
yeah,
what we
right.
call. Some
Very nice.
Latin American guys here also.
Very
See,
nice. Very nice.
this is my main station for demonstration, and here is
Yes.
the lounge zone, and here we
Okay.
have.
Oh, that's very nice. Very, very nice. How many people can you have there?
Usually we host 14 people. 14.
14. Yeah.
Yes.
Oh, that's very nice. And the microscopes you use there are they Zumax?
Yeah, we have Zumax mainly,
Yes.
and we have also size.
Oh, okay, great.
But for
Great.
trainings, we use Zumax microscopes.
Zumax, yes.
Mm.
We don't have Zumax in Brazil. Not
Oh,
yet.
really? Not
Yeah,
yet.
no, no. Yeah, we have Zeiss and some Brazilian brands, but Zeiss is the main microscope that we have over here. So we have a lot to talk about. First, for our Brazilian friends, I see that we have some Brazilian friends here, and tell us a little bit about yourself.
Okay, I'm just a crazy dentist from Ukraine. That many people know me from my Instagram account. So basically,
Yes.
I'm based in Ukraine, in Kiev, and my general occupation nowadays is aesthetic dentistry,
Yeah,
microscope driven, minimally invasive dentistry. So I do aesthetics, I do restorative stuff, and sometimes I do endo. Basically,
Andrew, yes, I remember that.
I
Yes,
started with endodontics, and now I
yes.
shifted more to aesthetics and restorative dentistry.
Okay, and tell a little bit of when and why did you find an interest in using a microscope in your practice?
Oh, that's a long story, but just to make it short, when I just graduated from the university, it was 2004, I started to work in governmental hospital with very old-fashioned equipment, techniques, and approaches. So I was really
Yes.
crazy about
Right.
this stuff, and there was a period of my time when I was actually thinking to quit
Really?
because because the
Was that
condition.
bad?
Yeah, it was that bad. Because actually, I'm not from the dentist's family, so I'm the only
Okay.
first dentist in my family. So
Yeah,
basically,
me
I
too.
was
Me too.
really
Yeah,
nice.
me
So I
too.
was not able to compare. Actually, I didn't know about modern dentistry and the things that we learned from university and things that we did in a governmental hospital was really like a 19th century. So I was
Yes.
just crazy about that. But then um, one good friend said that you have to go to private courses, to the private clinics. I went there and I was fall in love because I saw as a real dentistry, let's say, with a four-handed dentistry, with Rubberdam, with all this
Yes.
fancy stuff. And I started to learn from articles, from some videos, and I started to participate in online conferences and in online so-called message boards. You know Dental Town, right?
Yes.
So
Yes.
something like Dental Town, we had similar in post-Soviet countries. It was
Yes.
Russian-speaking platform, dental Russian-speaking platform. And there I saw people that worked with microscopes and they documented their cases and they shared these cases with us like clinical demonstrations. And I was super excited and it was super amazed by quality of the workflows that they did that time, the quality of documentation. So I said to myself that I definitely need to go to the similar way of dentistry. So I got the idea in my brain that I have to buy a microscope. Imagine that,
Microscope. Oh, that's
being in the
nice.
governmental hospital.
Yes.
So I was motivated. I was motivated by other people. So this is the story. I was motivated by other people to start using microscope in my daily basis.
Oh, that's very nice. That's very interesting. You know, sometimes, we hear a lot about countries in Europe. We hear a lot about the United States, dentists at those places. And many people, especially here in Brazil, don't understand that all over the world, we have very good exponents in our profession, very good clinicians, and so especially in those post-Soviet countries, we know very little about them, From you, I learned a lot. I remember first time I met
Really?
you was in Lithuania. Remember
Lithuania,
that?
2010, right?
Yeah, 2010.
10 years ago.
10 years ago. 10 years ago, yes. And then that Lithuania was a place that I really wanted to see because I have a relative that was from Latvia, somewhere around there. And I was amazed about the quality of everybody there. Everybody. We had Macedoni, we had some people from the United States, but most people were from the Soviet countries. We have a lot of people from Lithuania. We had some other people from Russia. And I remember we had a very good meeting. It was a very nice meeting. So, and I think really, definitely, I think you are one of the most talented people I've ever met. Really.
Come on.
I'm serious. I'm serious.
Now I become shy.
No. I'm serious about that. I'm serious. And I've known a lot of people. I know a lot of people, really. But tell me a little bit here about, tell me some of the clinical, Erica, tell me some of the clinical situations where you find the use of the microscope essential, where you think that you can't do it without a microscope. I know there are many of them, but tell us a little bit about some of them.
Look, how long do you use microscope? For how long?
For 20 years.
20 years.
20
so
years.
If I would ask you the same question, can you do dentistry now without microscope?
No way.
No way.
No way.
So here.
No way.
So for me, there are no special clinical situations that I have to use my microscope. I have to use my microscope for every single operative dentistry that I do for my patients. Sometimes I even do anesthesia with microscope.
Right.
It is not because I need that precision to do anesthesia with microscope. It is not. It's because I can sit straight, I can keep myself in comfortable position, and it is so useful for me just to do dentistry in that position. So if you ask me about specific clinical situations where we have to work with a microscope, I cannot give you an answer. So basically, if you start with microscope, you will do dentistry with microscope, every single patient, every single dental treatments with microscope. Even dental hygiene you can do with microscope.
Yeah, of course.
If you well trained, you can actually. You can. You have to understand that to be able to do everything with microscope, you have to pass a learning curve.
Right.
But it is a very good investment in this time investment that you will spend to learn microscope. It's a good time investment to your health. Basically, It's not just because of quality of treatments. For sure, if you start to use magnification in your daily basis, the quality of your treatments will be pretty high because you can see way better, way more, and you will be more precise. But also, you have to think about yourself.
Yeah,
you can tell. You can tell better because how long can you stay during the dental appointment? 10 hours per day, 8?
Yeah, probably.
5?
Well, right now we're in the middle of almost a lockdown here in Brazil. So now it's a kind of different. We're in a different situation.
Yeah, just because before this lockdown.
Yeah, but before that, about 10 hours. Yeah,
10 hours. So you still can do treatments for 10 hours.
Oh yeah, I can.
Actually, when you work with microscope, it is still difficult to do dentistry. We have to be clear.
Yeah.
Dentistry is very difficult profession. It is difficult to do dentistry, for sure. But when you work with microscope, it is slightly easier because it is more comfortable for yourself to spend time in comfortable position. That's it.
Yeah, of course. And we must remember that we work, as you said, dentistry is hard because we work in a small place, which is dark. It's difficult. You have a difficult access.
Difficult access, right?
Yeah. So when you use a microscope, you have the best lighting. That's the best lighting. There's no better lighting than the one you have from the microscope, because it's as if the light was coming straight from your eyes.
Yeah,
right?
for sure, exactly.
Yeah,
Yeah,
it's
correct.
a coaxial light. So you have no shadows. You have the best light. You're sitting in, as you said, in a comfortable position. So you have your shoulders relaxed, you have your head relaxed, and you can enjoy yourself. Some people think it's harder to work with the microscope. It's hard in the beginning if you don't have a proper training. But once you manage it, everything is easy. Everything is easy.
Yeah,
right?
for sure. Sometimes it takes longer to do some procedures. It takes a little bit longer with microscope. We have to understand this issue as well. But again, it is a very good time investment. And you know how you can compensate? Because some people, they used to say, if we will start to work with microscope, for example, for preparations like crown preps or veneer preps, it takes us like twice longer than without microscope. I say, oh, perfect. But how can you compensate that? You can rise up your prices and you will be fine. And, and you can still earn if money is an issue, but you will be in a comfortable position and you can promote yourself better with microscope.
That's right. But the thing is, I don't think it takes longer when you're using a microscope. Most
at the beginning,
cases,
at the beginning,
yes, at the beginning, yeah. But after you get used to it, let's say about 6 months, 8 months, it's a long learning curve. It's a long one. But after you're comfortable with it, you're as fast as you were before or faster, because you know exactly where you have to go for not to make a mistake, right?
Correct. Absolutely. Sometimes you are not faster, you are slower, but not because of difficulties that you experience, but because you see better and you know how much you need to remove caries, for example. You see the caries and you remove it.
Yeah.
Because without microscope, maybe you'll miss this part of the caries
removal,
of course. So it will be faster.
Many times. Yes, it's a lot faster. Are you going to show us some of your cases?
Microscope cases or what?
Yeah.
What kind of? Just tell me which one you want. Prosthetic or?
Yeah, I love your veneer preparation cases. I love your onlay preparation cases. If you can show us a little bit of how you do it.
Yeah, let me try to switch to my laptop here.
Okay, great.
So this is Rubberdam, because we actually are going to
speak
slightly about Rubberdam.
Yes.
Yeah, we have two. We announced actually. Where is some videos with the microscope, and we do preps.
Yes.
I want to show this, just a small video here. Wait.
Yes.
So actually, this is how we have our position here when we treat our patients.
Great.
So one of the very, very nice feature.
Yeah.
And at the same time, we can actually film or document our cases. So basically, we're not losing our time for documentation. So that is really nice.
Okay.
And another thing is which is super fine is that. Yeah. So this is the position that we can experience during the workflows. You can sit straight. Your back is straight. Your neck is straight. You can see everything you want. And you can do very tiny preparations, especially in that delicate areas as cervical zone, where enamel is pretty thin. And you can see how thin this enamel is and how much you need to prep to perform a very small finish line just to preserve that enamel. So that is very cool when you can do that with such a big magnification.
Yes,
and you can be straight, and your assistant can see also what you do, because you can project everything on the screen, through the screen, so your assistant can see what you do, and this helps to be more efficient when an assistant delivers some I don't know, instruments or whatever.
Right.
Nowadays you can apply your phone to the microscope, which is also nice. You see, you can put your phone, your smartphone, whatever you want. You can take very fast pictures, you can film, you can broadcast in social media. Like, you know, we do a lot of live sessions in Instagram, so we show our subscribers, our colleagues, how do we work with with magnification, with microscope. So actually, it's pretty nice.
That's very nice.
Nice stuff to show to people. So this
Very
is what
good.
we can do with the microscope. A very tiny preparation with a very small finish lines, like a 0.2 or 0.1, which is almost nothing, by the way.
Yes.
But what I have to say, you have to work with dental technician that also uses magnification. So let me just show you my dental tech, because he also works, see?
Yes.
He works with magnification. For example, when they separate model, when they provide the split cast model with a very tight proximal contacts, magnification is really nice for dental technicians as well, because they can be super precise with such approach that we perform, especially when they start to do this finish line. You see how delicate is the work of dental technician in that areas. So they have to work with magnification as well. And microscope is cheaper for dental technicians, by the way, and it is good because they can afford magnification easier than dentists.
Yes, of course. Yeah, you have an easier access to the what you're seeing. You don't have a tongue, you don't have a mouth, you don't have, the patient doesn't talk to you, right?
A stable position.
It's stable position. Yeah, that's great. That's great. Okay, so let's talk a little bit about isolation. So I see that many of your work, even preparations, you do under the isolation of a Rubberdam. And how did you come up with that idea? What was the necessity that brought you to that?
I know that you also work with isolation.
Yes.
Maybe sometimes.
No,
always.
Most of the time.
Most of the time.
Yeah, most of the time.
And you know that if you start to work with isolation, it gives you comfort, right? So we can talk about moisture control. We can talk about clinical benefits and advantages to utilize isolation. But the most beneficial thing from isolation is personal comfort. It is so comfortable for me to work with Rubberdam. This is the number one why I'm using Rubberdam, because it's dry, no cheeks, no tongue. I can control the process of my treatment. I have a very nice light reflections from the Rubberdam. So basically it is easier. And you know, when you work with microscope, Rubberdam isolation complement microscope. So basically microscope and isolation, they really love each other. They are like a happy family, you know?
Yes.
So when you do isolation, it's easier to access teeth. And when you work with microscope, you have both hands to work. Your assistant has...
This video is about benefits that you will have from our online workshop. Presence effect. This is a unique feature by Belograd Academy that literally moves you to our training center and you can stay close to speaker. This is like over-shoulder format. The training process is filmed through the video system from the microscope, and there are two more cameras broadcasting close-up and general view. This way, you can see everything in precise details. Efficiency. Do you agree, guys, that over-shoulder workshop with detailed video and explanation is way better than regular slides? The third benefit is convenience. So basically, you don't need to go anywhere, and you can study in comfort conditions, in your home, in your office, during running exercises, from your phone, from your computer, from your tablet, and you can do anything you want with the content. So join us as we shifted online education into the next level.
Also both hands to help you when you work with isolation. So everything becomes easier, okay? So when it's easier, that means it's better and the quality will be better also, because you are more comfortable. I want to say that I want to highlight that I don't do all my preparations with Rubberdam.
Of course, yeah.
No, I don't. Basically, I do preparations with Rubberdam when I have some defects, like a caries defects or old fillings that I have to replace, or teeth that we need to treat endodontically. So for this, I will put Rubberdam. Basically, I will put Rubberdam to do adhesive dentistry, when I do fillings, when I do direct restorations, when I do cementation procedures, when I do endodontic treatments. So for that stuff, I will put Rubberdam specifically. And if I need to prep these teeth, I will prep these teeth after treatments. For example, I'll put filling and then I continue my preparations with the Rubberdam on.
With Rubberdam on, yeah.
Yes, but when I have just normal aesthetic case, veneer case, for example, and there is no caries, nothing, for these specific clinical situations, I will not put Rubberdam. There is a thing that you love in Brazil, I know, the split down.
Yeah.
The Rubberdam with the open.
I don't like that. I don't like that.
You don't like that?
No,
it's more advanced. But I know some people that they put this split down specifically to prep anterior teeth. And I did this also in past, but I don't feel this technique is more, let's say, I don't know, better than just the Optragate for preparations of our anterior.
That's what I think. Yeah, it's not Rubberdam isolation. It's not. There's nothing to do with that. It's just a mouth. How do you say a mouth
retractor?
Retractor. Yeah, just a mouth
retractor. A more advanced retractor. Yeah.
Yeah, but you have easier things, to do that. It's easier than having to put clamps into patient's mouth without need. You don't. It's uncomfortable.
Yeah, to do that, for sure.
And so, tell us something about the instruments you use to place your Rubberdams. Which kind of clamps do you use? You use like routinely?
Yeah, I will show you. One thing. Sometimes I put Rubberdam specifically for preparation. Sometimes there are really limited cases. But I understand that Rubberdam in such a case will give me benefit and more comfort. For example, when we prep lower teeth or overlays or tabletops or sometimes for crowns, and the tongue of patient is always on our way. So for that case, if I cannot stabilize or secure tongue of my patient, my assistant sweating, fighting with the tongue. In this case, we can put Rubberdam with heavy clamp, with a heavy membrane, just to retract cheeks and the tongue of the patient, and then I can do my preparations with the Rubberdam. But it's not always.
Yes.
As for instruments, let me show you some instruments that we actually use for the Rubberdam isolation. Let me go back to this slide. So basically, these are clamps that we use for posterior teeth.
Yes.
I don't know if you have in Brazil this manufacturer. The name is KSK or Dentec. It is from Japan. It's very nice.
I mean, you can get that. Yeah, you can get that.
It's a very nice and the really high quality of the steel. So basically, the clamps are really high quality. So you can see numbers for posterior teeth, and also I do recommend to utilize hygienic Brinker clamps for posterior teeth. Brinker 1, Brinker 2, Brinker 3. They are clamps that you have to have because sometimes when you have pretty deep subgingival defects, these clamps will help you to make a proper isolation.
Yeah, B4 is very popular in Brazil.
Yeah, it is popular everywhere nowadays because since we start, not myself, but I mean dentists, we start to share our cases in social medias and internet, and there is no limit to share our knowledge. Many people, they start to see what actually people do with a high quality of dentistry, and Brinker 4 clamp was one of the most popular. So now it's clamp in the world. So here is for frontal teeth and from premolars. You can see the Brinker 4 here. And actually you can modify clamps for your own purpose. For example, you can make clamp more sharper. You can bend your clamp with a forceps to make it more active. So basically there are many options. How can you make customization of your clamp? For example, like in this case, when we have a pretty deep subgingival defect of posterior tooth, like this molar, and I tried a lot of clamps to isolate that one. And you know what I came from? I came up with the with a butterfly clamp, which is number 9. This clamp is used to isolate frontal teeth mainly.
Yes, right.
But in this case, it was super efficient to isolate posterior tooth. And I made some trick with that clamp. So basically the cheeks or jaws, the jaws of the clamp is like that.
Yes.
But the defect that I had in this case was more subgingival from palatal aspect. So I took forceps and I bent one of the jaw of the clamp from palatal area like this. So I customized clamp, so it was like that after customization, it went to that area, and I was able to perform that type of isolation.
Very nice.
I did that treatment. One trick for microscope users, by the way, you have to, if you are using shining clamps, you have to sandblast your clamps.
Right.
Otherwise, you will have a lot of light reflection. So basically, when you have sandblasted or satin clamp, it will be way more easier to work with magnification. But you can buy. They are ready-made satin clamps, or you can find also some black options for the clamp. So basically, it's like you know. The forceps that I like to work with, let me just find where are my forceps to place my clamps. I like to work with the long ones. Let me just see these ones, right? So here is the forceps that we use for rubber for clamp placement. You know, there are some forceps, for example, from Hygienic that are 90 degrees like this.
Yeah, right.
So they are okay, but sometimes for posterior teeth, if patient has mouth opening limitation, it's difficult, to work with that kind of forceps. But with these ones that I showed, it's way more easier. I can actually show because I had them here. Just a second.
Sure. Is the sound okay, everybody? Let me put the comments back again here. Okay. I put the comments back on just a little bit so that, you know, if people have some questions or something, we can see it now. So this is the forceps that I use. This kind of, I will put it on the black. I will put it on the black background to see better.
Okay. and the puncher, a regular puncher like this. Okay. So these are my instruments to work with Rubberdam. The clamps I showed you. Yes. With from the slide, and the forceps, and the puncher also. Okay.
Do you have a video where you can show us preparing your tooth with the Rubberdam on?
Let me check. For sure, I have plenty of these videos, but I am not sure that this video is in this presentation. But let me just
either anterior or posterior.
Take a look. For sure, I had a lot.
Yeah, I know you do.
Let me see if I do have. I had to. Yeah, actually, this is the case that I would like to share.
Okay.
Here is the video. Okay, yeah, perfect. So here we have a case where patient came with old composite veneers or crowns, whatever you want, because there are a lot of composite from frontal area and also from palatal side. And the request from the patient was to provide aesthetic treatment with porcelain veneers. Okay. So I started preparation before placement of the Rubberdam. So I started to use my depth cuts with a certain grooves, with a certain depth of insertion that we discussed with dental technician to give him enough space for ceramic veneer. Then I removed composite from the label surface, and also I removed composite from the filling areas, and I found that we had a lot of secondary caries. This is actually a very important thing that I would like to highlight to my colleagues, because sometimes people used to ask, do we need to remove old fillings to place veneer? Okay. And the answer is yes, if you do not know what is underneath. So basically, if patient came with that fillings that were made a few years ago or even a year ago in an unknown clinic, and you don't know how the dentists there work with adhesive protocols, do they use Rubberdam, how clean they prep caries out. If you know this, perfect, you can keep these fillings. Or if you placed this filling yourself a few years ago, and you are pretty confident that you removed all the caries and the bonding protocol was correct, so basically filling now is perfectly integrated into the tooth environment, let's say. But in the most of the cases, when you start to remove these fillings, you can find a lot of secondary caries, and you will be responsible for that, because if you will just put veneer on and after a while patient will come back with pain, with pulpitis or periodontitis, you'll be guilty because you are the last dentist for this patient. So you have to be careful. Okay, so we removed all the fillings there, removed the caries, and then we placed Rubberdam for treatment to place new fillings with adhesive protocol. And look what happened. Here at the cervical area, we still have a big composite overhang from previous treatment. So what I'm trying to say, at this slide, you cannot see that. Okay, there is under the gingiva some composite, but if I would start to remove now without Rubberdam this overhang of composite with my burrs or scaler or scalpel blade or curette, the gum will be like, you know, like I don't know how to say, like a steak. Like a steak, bleeding or whatever. But once I placed Rubberdam with a clamp, there is a gentle retraction of the soft tissues, and I can pretty confidently control this overhang with my magnification, and then I can and then I can remove everything from, look how much. See, well, this is a picture of taken from the microscope. So you can see a big overhang and some discolorations. And what also important is that you can see enamel, which is very nice.
Yeah, it's all in enamel. Very nice.
And we start to do our preparations, in this case, with Rubberdam. So basically, I was able to remove this composite filling in easy way. Sometimes I use instrument like a flat plastic instrument or spatula to protect Rubberdam over breakage. This is ultrasonic scaler also. We can retract Rubberdam with the instrument. You see, I help myself with another instrument. And then we do our preps with microscope and clamp on. So there are some sort of clinical cases when we do that approach. It's not for every single case I will place Rubberdam for preparation. Again, in this case, I need to place my Rubberdam because of the restorative treatment with direct composite restoration. And then I got all the benefits from the Rubberdam isolation with during my preparations.
Very nice, very nice.
The only thing that is pretty difficult to control in that cases is that where to localize your finish line. That is pretty difficult because, you know, when you have no Rubberdam, you can see the position of the gum, and then you can define where to go to place your finish line, supragingival or gingival level, or you have to go to the intraclavicular zone. So there are a few tips that I would like now to share. If you need to prep teeth with Rubberdam, how to define where to place your finish line. So the option number one, not like in this case that I showed. For example, you have patient with class 3 or class 4 fillings, but cervical area from label side is free, it's intact, so you can see enamel there. So what you can do before placement of the Rubberdam, you can do initial finish line just to mark where the gingiva was. And then you place your Rubberdam, okay, to remove caries, to treat the caries with composite fillings. And since you have this initial finish line performed before placement of the Rubberdam, now you know exactly where to stop your where to stop your finish line. So that is pretty easy. But in such a case that I showed you that composite was covered all the frontal area, it's difficult to find out where to stop your finish line preparation. So before doing any preps, we have in all cases, we have to understand where will be our finish line, supragingival, gingival level, or intraclavicular. If it will be, let's say, gingival level, you will have to see before placement of the Rubberdam, or you can do also the scratch line on the filling through to touch the tooth. So basically it's pretty difficult to explain, but when you prep composite, it's slightly softer than enamel. So when you go slightly down and then you will feel something harder, you stop. And then when you remove the composite, you will see your scratch in the tooth. So that is the gum level that you marked. But in this case that I showed you, we had to move our finish line slightly intraclavicular because patient had a high smile line. And in this case, we changed the color, so we had to mask the transition from the veneer to the tooth surface inside the sulcus. So in this case, when you put the clamp retracts soft tissues. It is also difficult to measure how much, but it's up to 2 millimeters sometimes. Okay, so you put the clamp. When you remove the composite, you see enamel, and then you prep not towards the very apical portion where the clamp is, but you keep like 0.5, 0.7 millimeters above the clamp. So you do your prep above the clamp, then you remove the clamp. Okay, you give about 10 minutes for gum to go slightly down. It will not go down full way as it should be because it was compressed by the clamp, but it will be still enough to evaluate where you will stop your finish line. So you do your finish line with Rubberdam, then you remove the clamp, give your gingiva go down, and then you go with your very final steps of preparations. So this is the trick.
Oh, very nice. What about posterior teeth?
Posterior teeth. People used to think that posterior teeth is impossible to prep with Rubberdam and with Microscope. But we have to say that it's difficult to prep even without Microscope and without Rubberdam. It is difficult. There is no miracle. Microscope or Rubberdam will not do dentistry instead of you. Rubberdam and Microscope will not make posterior teeth more closer to you, let's say. Yes. But since you will have retractions of soft tissues, cheeks, gingiva, tongue, and you will have light reflections from the Rubberdam, it will become easier to work with posterior teeth than without Rubberdam and without Microscope. So basically, I can say that sometimes, or let's say, if we compare, if you will give me a very strict question, for example, you will say, Maxim, imagine the situation when somebody comes and say, now, you have anterior teeth and posterior teeth to prep, but you have to define in which case you will use your Rubberdam and Microscope. You cannot use Microscope and magnification in both. Just one. Which one? In this case, if I will be let's say forced to be on the wall like this, and I have to choose between, like in Matrix, red pill or blue pill. In this case, I will definitely go for posterior teeth. I will use my Microscope and the Rubberdam for posterior teeth, because anterior is easier.
Yeah, of course.
More closer.
Yeah, of course. And you said something interesting, because posterior teeth is always hard. Doesn't matter if you have Microscope, if you don't have it, it's always hard. But it makes easier in many, many, many ways, Do you do like margin elevation when you have a very deep caries in posterior teeth, especially?
Yeah, sometimes. Yeah, for sure. Deep marginal elevation, the approach by Master Pascal Manier. Yeah, I do. For some cases, I do. Actually, I learned this technique from Didier Dici. And the good thing from Didier is that he is not limited just by restorative dentistry. He can also do surgery by himself. He puts implant by himself. Yes. So when he can concentrate...
Multitasking.
Exactly. If you have a person that is multitasking, that can do surgery, restorative, direct, indirect. So that person, if he says that in this case, deep marginal elevation will work, I will trust him, because I know that he can do also from the opposite side, or in a different way. So from Didier, I learned 3 clinical situations for deep marginal elevation. So first case, easy case. When you have defect that is localized in enamel still, but it's slightly subgingival, like in a sulcus. In this case, it's easy because you can do gingivectomy. Then you do your isolation, and then you go with your restorative treatment, and basically you don't need to do deep marginal elevation because you have enamel margin. and you can bond your indirect restoration with this enamel margin. And providing proper provisional restoration, you may redesign soft tissues, and you will have your margin open afterwards. Okay. The second option is when you have deeper defect, but the depth of the defect is above the bone level. Okay, so it's deeper than sulcus. Maybe it's in an epithelium junction. There is no enamel, but you are not at the level of the bone. In this case, you can do also gingivectomy, and then you have to perform deep marginal elevation by means of proper matrix adaptation to have your composite material properly used with a proper bonding protocol. In this case, the minimum thickness of composite that you are going to use to make this deep marginal elevation is about 1.5 to 2 millimeters. Okay? But the very important thing here is to perform a perfect fit of the matrix. Otherwise, you'll fail the game. You'll fail the game because of the periodontal disease. But anyways, in this case, we can do deep marginal elevation, and some surgeons fight with this, proposal, because in this case, they suggest to go for crown lengthening. But Didier Dice says that in some for some cases, if you have defect deeper and it's almost like a bone level, in that case, we have to go into the crown lengthening or orthodontic extrusion, or what else? Extraction and implant. Extraction and implant. Yes.
Yeah. Oh, very nice. Very nice. You did a live with Didier.
Yeah,
a few weeks ago, right? Yeah, he's such a great guy. He's such a great guy. Okay, do you have any other clinical cases you want to share with us?
I can show you. I think that I have a case for the deep marginal elevation, and I can show some steps of performance. Let me just check
10 minutes.
If it's here or not. Deep marginal elevation.
Okay.
It makes life easier, by the way, because when I worked without this approach, without deep marginal elevation, it was so difficult to prep, then to stop bleeding, then to take impression, you know, so it was a nightmare. It was a nightmare. Actually, I cannot see that I have it here. No, it's not in this presentation, sorry.
That's okay. No problem.
It was there, but yeah, it's not here, unfortunately.
No, it's
or
okay.
Maybe fortunately, I don't know. This is split down.
Oh,
this
yeah,
is split down.
Yeah. Why did you do that?
For this kind of stuff.
Yeah.
Because it's more comfortable. When we have, for example, splitted crowns.
Right.
And we have to take them out.
Yes.
I can put this split down because it will be easier for me to control the process of preparation to take these crowns out, like in this case. I took them out with Rubberdam, and also for patient it is comfortable because there is nothing to go into the patient's mouth. And then, since I was able to take also metal posts from these teeth, and I had also time to perform the primary endodontic treatment or the navigation to clean the root canals, I found out that we have to go for extra or additive isolation, because if I will be using sodium hypochlorite, you know, and it will have a contact with a gingiva, it will be bleeding or whatever. So in this case, it's one of the plenty option to perform the additional isolation. In this case, I just used a liquid dam or flowable composite. I put it all over the teeth, and then we go with our primary, let's say, navigation to make a dirty endodontic treatment, let's say, in this case. Okay. But when we go for the final steps, for sure, I prefer to go with a normal isolation where every single tooth will have its own Rubberdam and no gum will be exposed.
Okay.
So that is the trick. That is the trick. But where is my deep marginal elevation? For sure I had this. It was there, but I'm not sure that it's crazy. It's crazy because it was there.
What are you looking for? When was the last time you were here in Brazil? Was that 2015?
I was 2014, I think, or maybe 2015 during SBOE meeting.
Oh
I
yeah,
think it was there.
yeah. When I was president. Yeah, that's right. Yeah, at the beach.
Yeah. So yeah, it was nice location.
Yeah, it was nice.
Very
Very nice.
very nice location.
You have to come back again once all of this is
I would
over.
love to. I would love to. I have my friends nowadays, very close friends of mine.
Yes.
She's my classmate.
Yes.
And now she lives in Brazil with her husband.
Oh, really?
And they
Where?
always ask us to go Porto Alegre, I think, close to Porto Alegre.
Right.
And they ask us to come every year, but now with this coronavirus and lockdown, it's not
gonna
possible.
Take a while. Yeah.
Yeah. So here is the case.
Okay.
Finally.
Let's see.
A lot of presentations.
Yeah,
so that's two very interesting ones. So that first, in case if I see on X-ray that we have pretty deep caries defects in proximal areas, I can start my primary preparations without placement of the Rubberdam. In other cases, I can put Rubberdam first and then I treat my caries defects. So in this case, I expected that the defects were pretty deep, so I just started without placement of the Rubberdam. Right. And then look here, in this area, I made electrosurgery. With electrosurgery, I made a gingivectomy because the defect was deeper than sulcus. So I exposed margin with electrosurge, and then we place Rubberdam. And you know, this kind of isolation is pretty tricky, especially when you don't have from palatal side. You don't have extension. You have only here. But this part is slightly subgingival, so it is pretty difficult to manage this type of isolation. So you have to work with additive clamp, and Brinker 1 or Brinker 2 will be very essential because they're small and compact, so they will be able to give you that possibility to retract soft tissues. And there is a trick that I would like also to share. You see that I place clamp, then I place the matrix, then I open my clamp and put it again to secure matrix with a clamp. And then between matrix and adjacent tooth, it is not visible here, but between adjacent tooth and this matrix, I packed Teflon to bring Teflon tape, to bring this matrix to that portion to get a perfect fit of the matrix. And then we perform this deep marginal elevation with composite material at the same appointment. And then the second appointment was easier because everything was supragingival or gingival level. So this is one of the examples that we some type of dentistry.
Very nice. Okay, we're almost finishing our time here, and I have two questions.
Maybe we have some questions from participants also.
Okay, let's see. Let me open here. Let's see if we have something here.
I think you have in the Instagram, since you started this live, you have a special icon.
Yeah.
Where is the question mark? And you can see some numbers there. So you can open and see some questions there.
Yeah, over here. Okay. Brand of forceps.
Brand of forceps. Wow, I think it's Medici, Italian, but you can use any single brand with a similar design. It's really nothing special.
Okay. Another question here is which one is that adapter for the
smartphone.
Cell phone smartphone to the microscope? That's Zoomax, right?
This one from Zoomax, yeah. It is compatible with size, by the way.
Yes, it's compatible, right?
Compatible, you can use it with your size easy.
Yeah, that's very nice. We don't have it in Brazil, but it would be a very good thing to have it. Okay, another thing here about, that hand instrument that you use, when you're finishing your veneer preparation, the hand instrument.
Enamel chisel, you mean?
Yeah, enamel chisel.
I'm not using enamel chisels now anymore. No. I do my finishing lines, the final steps of my finish line preparations with a burr, with a low-speed electric motor, increasing handpiece, and delicate fine grit burr. So I'm not using enamel chisels for finishing lines. Sometimes I do use hand scaler in posterior teeth to remove some unsupported and chipped enamel, but now I'm not using enamel chisels for finishing lines anymore.
Yeah, usually I don't think, I tried to use some of them a few years ago, and I didn't think they're practical, I mean, you know, it breaks the enamel sometimes, you know, it's not practical.
It doesn't give you the value, let's say.
Yeah.
It's nice, it is a nice instrument, but it's, you know, there are some instruments that you can skip.
Yeah, that's right. You know what I like very much? I don't know if you have experience with that, ultrasonic instruments, you know, to do the finishing line. That one, I think it's more interesting. Let me see
it is also, you know, I have experience with ultrasonic tips to perform my finish lines. I don't like them also because they are not that stable as burr with electric motor and handpiece. But sometimes when patient has a very limited mouth opening where you cannot access with your handpiece, ultrasonic will help you because it is much more smaller and compact. So in such a cases when when you have limited access, they will help. Ultrasonic tips.
Okay. Another question. Today, with all this coronavirus stuff, are you doing something special in your microscope, in your setup, doing your clinical attendance? I mean, your clinical attendance, you know, to prevent contamination and stuff like that?
I didn't start treatment of my patients yet, but you know, there are some special covers from the microscopes, like I don't remember the brand. It is not available in Ukraine. Like a special covers, like aseptic covers for the microscope, but it's not available in Ukraine. What I would do to protect microscope against contamination, you know, there are some plastic frames.
Yes.
That you can just.
Yeah, that's what we're doing here. We're using that, and we are using an acrylic.
A tissue.
No, we're using acrylic. I have a picture here.
Acrylic frame.
Yeah. Can I show you this?
Yeah, sure. It will be nice to see.
Let me show you here. Let me see if I can. I don't know if you can see. You know, I covered my microscope with a plastic bag, actually a plastic bag. And then right over here, I have a sheet, a 2 millimeter sheet of acrylic that, you know, first, you know, we have to remember that the microscope keeps you away from the patient a lot more than if you're not using it, right? And here is what I have. You see? So it protects, you know, the spray from coming up. You know, I'm going to move it a little bit. You're going to see it better. That's something we made from Milena Peraro, which is an endodontist from Brazil. She had this idea. You see, it's about 45 centimeters from 38 centimeters. It's not centered. You know, I just fix it on the objective of the microscope like that. So that gives you a protection.
So it comes, this plastic piece comes with a hole for the
I made the hole. Yeah,
you
made the hole. Yeah, and then I fix it with a paper clip like this. You see?
Nice. Yeah.
Yeah, you know, it's something. You know, it's something. You know, very how do you say? Very homemade.
Yeah, but actually it works. Nice.
Yeah, it works.
Thanks for the tip.
Works a lot.
I will do the same.
It works a lot. Yeah.
Nice.
Okay. So
send me these dimensions to the WhatsApp, please.
Oh, okay, I'll do that. Sure, I'll do that.
Nice.
Okay. Any last messages to our attendees here?
You know, seeing is believing. This is the thing. As much you see, as better you do. And Rubberdam nowadays will become not just fancy stuff. It will be, I think, must, because Rubberdam also protects over cross-contamination. And believe me, many patients will ask you now for the Rubberdam isolation because they will read an article, some papers, some recommendations from other dental offices, and when they will come to you and you are not using Rubberdam, maybe they will go to another dentist because they want to protect themselves. So it's very good time to start using Rubberdam if you didn't use it before.
Yeah, I think the Rubberdam and the microscope.
And Microscope for sure.
And Microscope, because
Microscope
that
for
thing
sure.
I showed, because it keeps you distant from your patient. It keeps you uncomfortable. And even both of them, microscopes and isolation, it's something that it's hard at first, but once you manage it, once you master it, you can do it very easily. It really makes your life easier.
100%. 100%. Absolutely right.
Okay.
And the thing is that Rubberdam is easy to start to use because it is not that expensive as Microscope.
Yeah, right. You
but
probably
if
already
you
have it. Yeah,
if you will be able to buy, for sure, it's a very good investment. Very good investment. Yeah. Can I do some short advertisement or not?
Sure, of course. Please do my guess.
I would invite people to join our online courses in our webpage, which is online.belograd.com. This is our webpage. So in this webpage, they will find our online advanced course about Rubberdam isolation. So it's here, Rubberdamology.
Very nice, very nice. Very good. You have a very nice training facility, my friend.
Thank you. Thank you.
That's a new one, right? That's a new one.
This is the new one, yes. Yeah. We just launched it in January this year.
I remember that. Yeah. You used to have in another place, right? Another city?
It was a city side of Kiev, 30 kilometers away from Kiev, in a small village in the forest.
Okay, so please invite our friends, to go to your place also. Whenever traveling is, whenever traveling is possible, it would be a great opportunity.
Yeah, I'll be more than happy to host everybody.
Yes.
77 countries. We were visited by colleagues from 77 countries already.
Really? Oh, that's very nice.
We had people from Brazil, by the way.
I know.
We had people from Brazil.
I know. Marcelo Calamita was there.
Marcelo Calamita was
here. I remember that. I remember he was there. Well, my dear friend, thank you so much for sharing your knowledge with us, all your expertise, all your passion for dentistry, for the use of for high-level dentistry. That's very important. That's very motivating. And as I said before, you are one of the greatest guys, in our planet, in our profession, really. You're very nice, very talented, and you have the gift to teach people what's important and in an easy way to do that. So
thank you very much.
Thank you very much.
Thank you, Jose. I can say the same about you, because when I saw your work, your cases in Vilnius, 2010, I was amazed with the quality of composite restorations and the microscope approach that you actually used. So basically a very kind person. I'm really happy that I got this opportunity to meet you and to know you in person. And I wish you all success, to be safe, to continue your amazing work, to teach people, to interact with people, and to bring your beautiful ideas to the dental world. Thank you
very much, my friend. Thank you, everybody, for watching. This live will be saved in my Instagram. If you want to tell your friends, to watch, it will be online for 24 hours. And once again, my friend, take care. Be well. Be safe. Okay? And say hello to your wife, to your kids. Okay? I hope to see you soon whenever we have a chance again.
For you. Perfect.
Okay?
Thank you.
Bye-bye. Take care, my
We're
friend.
in touch. Bye.
Bye-bye, everybody. Obrigado. Thanks for watching. Bye-bye.